As mentioned today, we're going to be looking at osteosarcoma, quite a big topic, but I have tried to make it concise. I'm happy to take questions after this, as I probably will not cover everything around this topic. I have nothing to declare. Osteosarcoma is the most common bone cancer that affects adolescents and young adults. Over 85% of patients are below the age of 25. It's characterized by osteoid-forming malignant spindle cells. The disease-free survival rate has improved over the years, as I think Dr. Machete mentioned. However, it still remains relatively low. Up to 20% of patients present with measurable metastases at diagnosis, and the remainder, which is the 80%, have micrometastases. Majority of them are to the lung. However, it must be mentioned again that primary bone malignancies are rare malignancies, fortunately. They make under 1% of cancers worldwide. As can be seen here in the data from the UK and the USA, that other cancers still dominate the list when it comes to cancer deaths, largely lung cancer, as can be seen here in the pie chart from the National Cancer Institute from the United States. The outlook was very bleak for osteosarcoma patients in the past. I think Dr. Machete also alluded to it. In the 70s, the standard treatment was an amputation with a 5-year survival rate of only 20%. Then in the late 80s, they then were introduced to adjuvant and neoadjuvant chemotherapy, which really changed the playing field. Plus an improved surgical technique and surgical technologies. Limb salvage largely replaced amputations as treatment standard. And this actually took the 5-year survival rate to nearly 80%. The 90s mostly focused on gene therapy, but largely this was outside clinical practice. And in the 20th century, we focused more on stem cell therapy. We really have not moved on much beyond that point. There are quite a few issues when it comes to osteosarcoma. Part of the challenges, as covered quite nicely in this publication, is that there are multiple implicated mutations of tumor suppressor genes when it comes to osteosarcoma. Examples being like your P53, RB1, cyclin-dependent kinase inhibitor 2A and B. That's one aspect of it. Studies now are also focusing on the tumor cell genome and the microenvironment. However, when it pertains to osteosarcoma particularly, both these are quite highly heterogeneous, and the biology in general is quite complex. This makes it very difficult for drug companies and drug scientists to develop new therapies that are more targeted therapies in the effort to try and avoid side effects that are associated with chemotherapy. Apologies for the background noise. This is a widely known table which shows the different types of osteosarcoma. 85% of the patients that we treat have conventional osteosarcoma. And you can see the World Health Organization modification of that is shown in the slide here. Under conventional, they further subdivided it to osteoblastic, chondroblastic, and fibroblastic. This type you mostly find in adolescents and young adults. 50% are osteoblastic tumors, with the remaining 50% equally spread out between the two subtypes. The telangiectatic subtype is under 4% of the patients that we treat. However, we still see a few of these patients in the unit where I practice. And then what I would also want to highlight is your surface osteosarcomas. These are rare osteosarcomas compared to the two that I've just mentioned. They carry a slightly better prognosis, partly because these are slow-growing osteosarcomas. So you have, they allow you that time frame for intervention. Secondary osteosarcoma we see in older patients, largely from either previous radiation for other sarcomas or from Paget's disease, fibrous dysplasias, or even chronic osteomyelitis that we spoke about the last time. The radiographs on the screen are just merely for demonstrations of some of the types that we spoke of. The left radiograph is that of conventional osteosarcoma with those typical features that you find with an osteoblastic matrix, extensive soft tissue component, and a significant periosteal reaction, and the location also is very typical. Then the middle picture depicts a periosteal osteosarcoma, which is a form of surface osteosarcoma. This, as mentioned, carries a slightly better prognosis because it's slow growing. On the far right, this is what telangiectatic osteosarcoma would look like. I don't know if the picture projects very well. It doesn't on my side. Apologies for that. So the symptoms are present for several months before the patients come to us. On average, patients don't come before 3 months to us. Initially, the pain might be activity related, but ultimately it is also present at rest and they have night pain. Incidental trauma is reported by many of these patients. These are normally young patients, you're 15, 16 year olds, and you tend to find that the parents would want to attribute the pain to something, and their fallback to is always that minor trauma that happened at some point. 10% of the patients will present with a pathological fracture, and unfortunately, by the time this happens, the prognosis is slightly more unfavorable than the other groups. And as mentioned before, many of our patients present with lung metastasis already from the first time they get to be seen by us. And this paper speaks of this. Like, these two local professors published this paper in 2012 in the South African Medical Journal, and they found that 66% of osteosarcoma patients treated in their unit had metastasis by the time they presented. This is largely in line with what they report in international literature as well. The rate of micrometastasis is even higher than this, because majority will come with lung metastasis, followed by that is bone metastasis. I'm sorry again if the image doesn't project very well, but it's a color-coded image that shows you the regions that are predominantly affected when it comes to osteosarcoma. As mentioned by my colleague, majority of them are around the knee, which is your distal femur and your proximal tibia. In fact, I would have made the proximal humerus into the color purple as well. We quite often see osteosarcomas in that region. And the reason for this is that osteosarcoma prefers region of high bone turnover, as is the case in the distal femur and the proximal tibia. The role of plain radiographs cannot be overemphasized, because the diagnosis is actually made on plain X-rays and obviously confirmed by biopsy with the help of advanced imaging. But largely, you need to be able to interrogate the X-ray to make the diagnosis. And this publication actually describes that very well. But we'll briefly go through it. The features that I described here are largely for conventional osteosarcoma, which is 85% of the patients that you're going to see. And please note that the X-rays displayed here are just for demonstration. They are not of the same patient. So these are largely osteoblastic, have an osteoblastic matrix or osteosclerotic lesions, and they like the metaphysis for the reasons I've mentioned, mostly around the knee with ill-defined transitional zone, which means that you are unable to discern where the tumor starts and where the normal bone starts, versus your benign lesions where you can easily tell the outlines of the tumor. This is not the case in this type of tumors, and they also have a very significant soft tissue extension plus a periosteal reaction. Different things can give you a periosteal reactions, and some have tried to classify periosteal reactions differently, ranging from benign to aggressive. With this type, you get what's described as an aggressive periosteal reactions, and those can be subdivided into laminated types, which is your onion peel type of periosteal reaction, or a sunburst type of periosteal reaction. I think the initial image that I showed of the proximal humerus actually showed that quite well, and the other one would be a Codman triangle. What this tells you essentially is the rate at which the bone is trying to repair itself. So the rate at which the bone is reacting to the process is happening. And the more aggressive and the more malignant the tumor is, the higher this rate is. And so you get periosteal elevation much faster than you would get in a slow growing tumor. And so even though you cannot use this, it's not sensitive enough to say what type of tumor it is, but it gives you a pretty good idea of whether this is a malignant process or a benign process. We add advanced imaging as part of the workup, and this is for both local and systemic staging. The role of MRI includes assessment of the extent of the mass and for preoperative planning. It helps one discern where the important structures are and if limb salvage is possible. As you can see the middle picture, this is not an osteosarcoma, it's also just merely for demonstration. You are able to see, as you can tell anteriorly, that there is a patella, so you're at the level of the knee, and you can see quite well how much the lesion extends, and you can also see where the neurovascular structure is, and you can also are able to assess which compartments are involved, and that's where the planning for surgery part comes in. It also helps. Yes.
You can use your mouse to demonstrate on the slides. I think we can see your cursor nicely. Yes, thanks.
Sure. Thanks, Dr. Mawel. I didn't know my PC could do this. Okay. And then the other things we use it for is to identify skip lesions within the same bone, and also the extent of bone marrow infiltration. CT scans, particularly when it comes to osteosarcoma, we use it for systemic staging to identify especially lung metastasis, or in areas of complex anatomical regions like the pelvis. We might use a CT scan. The PET scan is something that is probably underutilized, especially in our unit. This scan detects metabolic activity of osteosarcoma or any process, particularly because we're talking about osteosarcoma. It uses a radioactive glucose analog. And actually one meta-analysis, I think it was published in 2019, showed that this has an accuracy of above 90% when it comes to making the diagnosis, staging, and also monitoring for recurrence. Certainly something that we could make more use of, but we don't use it as often. Mencken in this paper described why it is important to follow strict principles when it comes to taking a biopsy for these patients. We commonly do incisional biopsies in the unit. Other centers do percutaneous image-guided biopsies. That's most likely not as important. But what is more important is that you need to understand the hazards that come with this and what principles you need to follow prior to undertaking this. And part of that is that the patient must be fully worked up with adequate imaging. This includes the MRI as well, because then you are able to plan as to which part is going to be the most representative part to get a specimen from and what tissues you need to involve in that specimen. The other prescribed principle is that the surgeon that does the biopsy should be the surgeon that's going to do the definitive surgery. However, there is modification to this, provided that there is clear and direct communication between the surgeon that does the biopsy and the surgeon that's going to do the definitive surgery. We prefer longitudinal incisions that are in line with the muscle compartments, and all of these principles are mainly aimed at avoiding tumor contamination into areas that might have not had tumor to begin with. So also tourniquet use and controlling your bleeding intra-op is important. We don't want you to cross compartments during the biopsy. If you leave a drain, you should leave it in line with the incision of the biopsy. And of course, the specimen needs to be a well-represented specimen, because we do get cases where the specimen is just not representative and it is sent back and the patient has to go back to theater for another biopsy. When it comes to staging, we use these two systems. The American Joint Committee on Cancer has the one as shown on the left side of the screen. But largely, the more recognized staging system is that of Enneking. It's also probably the oldest. They're more or less similar if you actually interrogate them a bit more. However, the AJCC has gone to the extent of actually measuring the sizes of the tumor that you're dealing with. And then when it comes to principles of how we manage these patients, these, as mentioned before, really started coming into play in your 70s, 80s, and beyond that. And they've actually improved the outcome for patients. And they follow this format regardless of what your surgical resection plan is, whether you're planning to do an amputation or you're planning to do limb salvage. And these entail neoadjuvant chemotherapy or preoperative chemotherapy, then surgical resection after that, followed by adjuvant chemotherapy subsequent to that. Coming to preoperative chemotherapy, as mentioned, this came into play for osteosarcoma particularly in the 1970s. And what it tries to do is to reduce the reactive tumor zone. It has been shown to increase the success rate for limb salvage. It also reduces the recurrence rate. We are also able to get prognostic information following this when it comes to the rate of tumor necrosis. What we ideally aim for after preoperative chemotherapy is a tumor necrosis rate of more than 90%. below are just some examples of the regimens that we use. Now, for the longest time, we've been using combination chemo and not monotherapy. Just on the point of histologic response to neoadjuvant chemotherapy, it was based on this classification that is displayed here, HUVOS, for tumor necrosis rate of 90. So we're looking at a HUVOS type 3 at the very least. If we get anything less than this, it might suggest that there is a risk that the patient might have chemo resistance, or we might not be able to continue with the same regimen for adjuvant chemotherapy subsequent to this. And we aim to do the surgery 4 weeks after the last dose of preoperative chemotherapy. And this is safe because there is literature out there that shows that delaying surgery from the time of diagnosis to allow for this chemotherapy doesn't affect the survival rate of patients, regardless of what surgical resection you decide to do. Now, as far as surgical resection, you could either do limb salvage, which is predominantly what's done nowadays, or an amputation. Since the introduction of chemo, limb salvage has definitely overtaken amputation and is performed for over 80% of patients nowadays. Our local experience might be different. A lot of the literature is also reporting a higher survival rate for limb salvage patients than for amputation patients. However, I do think that patients requiring an amputation are normally sicker and present with late-stage disease to begin with, and perhaps that's why the limb salvage cohort does slightly better. Also important is that you must have prospects of a functional limb if you're going to attempt limb salvage, and patients must be motivated for that. It's no point after having evaluated your MRIs and realizing that you're going to have to take a huge part of your muscle compartments and you still go for limb salvage, because most likely that limb is not going to be functional. And so there's no point in attempting limb salvage. Unfortunately, patients that come with pathological fractures do not qualify for this, because in those patients, we know now that the rate of contamination of normal tissue by tumor is very high. As mentioned, our experience is still very different from what the West is describing. I have no formal numbers when it comes to this, but arguably I would say we still perform an amputation for 50% of our patients. But like I say, I have no formal data on that. The images again are not from our unit per se, but they are merely for demonstration. If you look to the far left of the screen, that would be an example of a patient that underwent a tumor megaprosthesis, where post-tumor resection, then we use prosthetic implants to reconstruct the limb. Then the image after that is an example of an allograft reconstruction. The resection is done, but you'll see that the midsection of the femur is not native to the patient, and that can be fixed with either a nail as shown here or a plate. More often than not, we use nails because they span the whole length of the bone. And next to that is an image showing you an example of a vascularized fibula graft that was used to bridge the gap. In your younger patients, especially kids, the last picture is actually a good option, which it's not as clear as the other pictures perhaps, but it's an example of bone transport. And then subsequent to this, it's post-operative chemotherapy, or probably commonly known as adjuvant chemotherapy. This we normally start 2 weeks after the surgery, or once we're certain that the wound is healed. The regimen that was used for pre-op chemo remains the same, unless the tumor necrosis rate was less than 90%, then we might still keep it the same, but provided we've excluded that they don't have multi-drug chemo-resistant osteosarcoma, or for whatever reason, but we need to reevaluate why the necrosis rate was below 90%. Again, this is also a prognostic factor, because the patients that don't respond very well to preoperative chemotherapy also have a shortened survival rate post-treatment. And this part of the reason we use it is for systemic treatment for residual disease. Other therapies that are mentioned in the literature is radiotherapy. However, osteosarcoma is notorious for being resistant to radiotherapy. Immunotherapy is another promising aspect as far as treatment is concerned, because osteosarcoma is a macrophage-driven sarcoma, and research is still undergoing to try and exploit this aspect. Gene therapy, especially for our local situation, is still largely an experimental exercise. And in practice, I would have to consult our oncology department to see how often we use it, but we've never used it, not that I'm aware of anyways. Future therapies are looking to exploit what we had spoken about in the starting slides when it comes to microenvironment of osteosarcoma, and also around the genome. Tyrosine kinase signaling is known to regulate a number of cellular mechanisms that are critical for tumor survival. And so if we block this pathway, we actually can use this to treat these patients. And these processes include cell growth, so cell proliferation, or formation of new vessels. This is being looked at as to try to find target selective chemotherapy, because this obviously would come with lesser side effects. They've tried intraarterial cisplatin before, like to improve the histologic response of the tumor. I think one small trial showed a 90% 6-year survival rate, but unfortunately bigger trials have actually shown a survival rate less than that. I think it was under 70% in one of the trials. And then LMTPPE stimulates the formation of macrophages that are able to actually fight the tumor cells. And also this is still on clinical trials level, and I'm not aware of it being used in practice at this point, not in this country. Zoledronate we use for patients who have osteoporosis. It assists with bone formation and like blocks osteoclast function, which is a huge aspect in osteosarcoma. However, it also hasn't done very well in clinical trials. I think that's mainly it, but I also just had I think 2 clinical cases that I just wanted to show quickly just for demonstration. This picture we saw previously, this was an 18-year-old male who came with a fast growing mass of the left shoulder. He reported a 4-month history. Also at the time he presented, he had fractured his humerus. It was a low energy event. He was seen at local clinic and was treated conservatively at that time. I suppose there might have been an issue with X-ray features at that point. But again, all to say, we should be interrogating these X-rays probably more closely than we are. The mass eventually increased in size and included the entire shoulder region, as you can see in this clinical picture. What you see there on the lateral aspect actually was a previous biopsy scar. And again, the X-ray shows your typical features, an aggressive tumor, osteoplastic, it's in the metaphyseal region with a significant periosteal reaction. If you see, if you look at on the lateral aspect of the mid shaft of the humerus, you will see that periosteal reaction just below the actual tumor. An MRI was done for him as per workup, and on the axial cut, you're able to assess that the tumor is actually in the entire region. The vascular structures are engulfed within the tumor. And as anticipated, biopsy confirmed chondroplastic conventional osteosarcoma. And then subsequent to this, we already knew that at this point, he was headed towards an amputation, but we still discussed with the medical oncology team for him to get a neoadjuvant chemo prior to that. However, in that process, this happened. And now at this stage, he came with this fungating mess in terrible pain. Then we decided to not wait for him to finish cycles of chemo, and we took him for an amputation. So unfortunately, we do see these patients, many of them will come at this stage, and many of them will end up with an amputation. And I think subsequent to this, under less than 3 months, he demised. The next patient, not as bleak, 23-year-old male, came with a 3-month history of pain and a mass on his left knee with night pain, no constitutional symptoms. Typically, like the constitutional symptoms set in a bit later on in the history, but it's still something that you should ask about. And again, it's a very similar picture to the one we saw previously, just a different location, and you can see on the MRI on the next slide. However, for him, likely he didn't have any metastases at the time that we saw him. So he also underwent neoadjuvant chemo before we decided to do a tumor resection and a prosthesis for him. On your far left, the image is longitudinal, and the knee is to the left of the screen, just showing the mass. And that's the picture next to that is just how we planned or we made our incision rather. You'll see that island of skin there in that incision. That is part of the biopsy incision that we must excise, as mentioned, as part of biopsy principles. And then you move on to the next picture. You can see the knee with the patella flaps to the side, and we then excise the tibia being clear. So we would have done an MRI prior to this to also study the bone marrow and see how far below the tumor we need to go, because often than not, the bone marrow infiltration is actually beyond the actual tumor itself. And then the last image just shows you a trial implant, which we use for tumor processes. So that's not the definitive implant. The definitive one looks nicer than that. The last case is a 14-year-old female, again, painful mass, left distal femur, no mets at the time, also went through X-rays. So these are the typical X-rays that you will get. Sorry, the X-rays, actually these pictures don't project very well. But if you look at the lateral view of the knee, you will see that nice periosteal reaction with the elevation of the periosteum there towards the mid shaft of the femur. Sometimes it's not as obvious, especially in other processes or early on in the disease, but it's something that you must particularly look for. And because of that, she underwent chemo. The tumor was much smaller by the time we took her for surgery. Again, a medial approach, we excised the distal femur, part of your excision is that you don't open the tumor. So you stay away from opening the tumor within the surgical field. And then we inserted a distal femoral prosthesis for her. And she underwent a subsequent adjuvant chemotherapy, and she's done well. These X-rays are not the best views. I think they only show the lateral view, but that's what she ended up with. Thank you.
Thank you very much, Dr. Ntombela. Very nice presentation again. I'm sure there will be some questions in the Q&A that are already there, but maybe before I take some of the questions there, I wanted to ask, maybe first to comment, to say, maybe I understand why you say that still most of the patients in this country still undergo amputation. Probably it's the same reasons that almost any other cancer. The survival is not the same as in other countries in South Africa because of late diagnosis, probably, and late presentation. Probably that's one of the reasons. But the questions that I had was, in terms of the children, like for example, the cases that you've shown there that they've had the cancer removed and then they have a prosthesis, because they're still growing, do they come and then do you change the prosthesis and put another one as the other leg grows, when the child grows taller? Or what happens? Because I think I was also under an impression that when you put in like a prosthetic joint or something, it's meant to be there and you have to, like, it can't be there for more than 20 years or something. I don't know about that information. I just wanted to know, like, how do you do with this young children who already have prosthesis?
Yeah, so that's why the other options actually offer slightly better results, particularly as far as that point is concerned. That the one option I showed was with the ring fixator, where they do bone transport afterwards.
Okay.
But for these kids particularly, it's the outlook is so bleak that we probably are not gonna be having to revise this. I'm still to see a child with osteosarc that lives beyond 5 years. But these ones particularly, because they are highly constrained implants, their failure comes at a much earlier stage than your implants that you use for your traditional joint replacement in the elderly, for like osteoarthritis, those type of things. So these ones tend to loosen much earlier. If they go beyond 5 years, then that's already a good result. But more often than not, if it really gets to that point, we revise many of them before 5 years. But chances are, at 5 years, the patient will not be with you anymore.
Oh, okay. All right. No, thank you for that. So there's some questions on the Q&A. There's Anonymous who wants to know what is the survival rate of osteosarcoma, if it's a low-grade tumor for a 14-year-old boy. There's Dlamini Zwandile wants to know, is there a relationship between HIV and poor prognosis in patients with osteosarcomas? And the third question is about survival rate in a patient with lung metastasis. Maybe your comments on that before we take other questions.
Yeah, sure. So for patients with low-grade osteosarcomas, or even like your surface osteosarcomas that we spoke of, periosteal, those ones have a slightly higher 5-year survival rate than conventional osteosarcomas. And the recent literature, but it's again a paper from the West, quoted up to 80% of them will survive beyond 5 years. But the unfortunate part is that those are very rare cases, because like mentioned, 85% of the osteosarcomas that we see are conventional osteosarcomas. And more unfortunately for our setting especially, is that by the time you are seeing them, the tumor is a massive size, and they most likely have lung metastasis at that point, which drops the 5-year survival rate significantly to below 60%.
Mhm.
And then as far as HIV is concerned, I have not come across anything in the literature that seems to suggest that there's a direct link between osteosarcoma and HIV as far as prognosis is concerned, or as far as the one causing the other. I'd have to be speculating. HIV, what I've come to note, especially when it comes to either infection or orthopedic cancers, is not really a factor per se, unless you have a low CD4 count and a high viral load. But it in itself has no bearing. I'd have to look up maybe literature to see if there is an association between HIV and osteosarc. But just from my understanding, I don't think so. But don't quote me on that one.
Okay, all right. The other question is from Lishogonolo. I think I also don't have answers to this question. She's asking about in the GP's perspectives, what are the red flags that they can look out for during history and clinical examination to make sure that they don't miss any early signs? And I understand, because I think you said it also in one of the slides, that this constitutes about 1% of all cancers worldwide. So there is no screening test for it. So maybe I think the best thing would be to, what are the red flags, or what is it that should raise eyebrows to say, no, maybe this is suspicious? Or maybe before you comment on that, maybe also comment on whether there is any association with any familial cancers. Is there any genetic predisposition? Is there anyone who's particularly at risk of having osteosarcoma?
Okay, so concerning familial risk, there are associations with other syndromes when it comes to osteosarcoma, because some share common gene mutations as far as your tumor suppressor genes are concerned. So from that perspective, like your P53 is associated with many other cancers other than osteosarcoma, and your patients with retinoblastoma from RB1 mutation also are at a high risk of getting osteosarcoma. Patients with your Li-Fraumeni syndrome are also at a higher rate of osteosarcomas. But from the fact that someone in your family has had it before, you're at an increased risk, I have not found that in the literature. But just from the common gene mutations that you get, then there can be an association in that respect.
Okay. And then oh, no, sorry, pardon, you may speak.
Sure. As far as what one can do to not miss it, like from a general practice level, I think the one important thing is the high level of anticipation. A high level of suspicion is to first be aware of it. And like I said, if you have this basic information as to the demographics, especially of the patients affected by this, and the fact that many of them will come report some form of trauma, like the history, if you really go through it, you'll pick up a lot of these red flags. Mainly, it's like patients that are in their second decade of life. It's around the knee. So already you are getting alerted from that. And if they describe the trauma, you get the sense that well, it doesn't really warrant a fracture or this type of swelling. You know, some the kids will come with someone having bumped them in school, not even playing or anything like that, and they come with a massively swollen knee. That should already be raising red flags. But I think the history will direct you more. What's probably even more valuable is your interrogation of the X-ray. So already when the history is seeming a bit iffy, you might be getting a sense that it's probably trauma, bumped knee, and then you don't see a fracture. Look at the X-ray a bit more, because sometimes early on, like the periosteal reaction might not be overtly there. The actual tumor might not be as clear, but more often than not, especially in our setting, because patients will not come to you early, you will see X-ray changes. So it's really just to be on the lookout and have a high index of suspicion, especially if you're seeing that particular age group.
Okay, and then any association to say maybe if the patient already has chronic inflammation from osteoarthritis or something, maybe that puts them at risk.
Talking about your older group now,
yes.
your secondary osteosarcomas.
Yes.
Yeah, so those ones, they do mention osteoarthritis as something that could secondarily get osteosarcoma. I have a hard time believing that. I can't see the science for it, but I don't want to dispute it too much. Normally, your elderly patients get it from like things that they might have either missed in their younger lives, like your fibrous dysplasias, or like Paget's disease could easily get secondarily into an osteosarcoma, or even chronic osteomyelitis can secondarily turn into an osteosarcoma. But those make up a significantly small group of patients. You are more likely to think of something else before secondary osteosarcoma in a grown-up, like your chondrosarcs or something like that. But it certainly can happen.
All right, I think we only have 5 minutes left before it's 7 p.m. There is 4 more questions. Brian is asking about how is the 5-year outlook for limb spared cases in your setting, in your practice, and is there any attributes linked to the good or poor prognosis? And the other question is about, does early detection of the osteosarcoma change the outcome or survival rate? And then I think maybe you've mentioned that already. And what is the rate of remission post surgery for osteosarcoma? And then the last question is about, is it usually one joint that is involved, or can it affect more than one bone at a time? I think this will be the last group of questions that we're taking.
Sure, I should have been writing them down, but you just remind me of the ones that I forget. But the recurrence rate, like local recurrence, is up to 13%. Of patients can get local recurrence. More often than not, what happens is that we pick up micrometastases that had been missed at the time of presentation because they were not measurable. So patients normally come back with that now the metastases are more established, and then we're able to pick them up. But yeah, local recurrence is up to 13%. And then what was the other question?
It was about does early detection change the outlook on survival rates?
Yes, certainly. I don't know if it's measurable as to how much change it brings, or I haven't come across anything like that. But for our patients that even come with micrometastases that are not measurable at the time, versus the ones that come with metastases already, it's a matter of the timing of presentation, like how soon after. The shoulder case that I presented, he said he had noted it for 4 months, but I absolutely do not believe that. So I think it was also someone who didn't stay in the country and only came to the country for that reason. So it was probably way more than that. But the sooner you pick it up, the greater the chances are for limb salvage, one, and it certainly changes the 5-year survival rate. And then I think the other question was on prognostic factors. Might have alluded to it.
The involvements, yeah.
Oh, the multiple joint involvement.
Yeah.
That is extremely rare. It is described. I'm still to meet a surgeon who's seen, I haven't even seen a case report of multiple joint involvement in osteosarcoma, but it's more likely to be a metastasis of the primary tumor than it is to be another primary itself.
Okay, I think we have answered most of the questions, except for one which was not in the Q&A. I think this is somebody asked it on the chat about what if you do a biopsy and then, well, because you were suspecting osteosarcoma and then it comes out as negative, should you just accept it, or is there anything else that you can do?
We've actually, that's a very relevant question. We've actually had to dispute a few biopsy results just based on our clinical findings of the patient. We've had osteosarcomas labeled as giant cell tumors in other instances, but because you also get what's called a giant cell rich osteosarcoma. So like giant cells might predominate the histology, but also once you've evaluated the patient and once you have the history and the clinical examination, you normally have grounds to dispute some of these biopsies or send another one or discuss it with a more senior pathologist. And more often than not, the results change.
Maybe, Doc, before we close, thanks again. There were 2 questions in the chat around tumor markers, and I think these are general practitioners. Seeing that clinically, it seems like it's a condition we miss. Are there any, someone was even asking about LDH. Are there any specific tumor markers that can be checked?
So LDH particularly, we do that as part of staging or workup, because especially your conventional osteosarcoma, it has both osteoclastic and osteoplastic activity. Alkaline phosphatase is a marker of more osteoplastic activity, and then LDH is more of a marker for the activity of your osteoclasts. But those also have a prognostic value, the higher they are. Because they're meant to balance each other, but they also reflect the degree of bone turnover. So if they are very high, those patients, again, are the patients that have a bad prognosis versus someone who comes in when those are still low.
Okay, all right. I don't think there's any more questions. Yeah, Dr. Ntombela, thank you very much for another good seminar. And I think we've all quite learned a lot from it. I think even if you see on the chat, everybody has enjoyed your talk. Thank you very much for your time as well as for the talk. Dr. Mawela, can we close the session, or is there any announcements or anything else that needs to be said?
No, there's a big question. People have not seen Dr. Ntombela, so they are saying as he says his closing remarks, they just want to see his face. Then just say your closing remarks, but please allow people to see you so that when they see you next time, they can say, that's
the guy.
I thought I didn't think my camera was working.
There it is. It's working very well.
So no, thanks, colleagues. And again, thanks, Dr. Mawela, for the invitation. I'm happy that the colleagues enjoyed it, and I hope we could improve clinical practice going forward as far as these cancers are concerned.